Hello, this is Faith Campbell for my video project number 1 from 2/22/25. My patient admitted themselves to the ED after not having a bowel movement in 13 days. She also was having pain and nausea, as well as bowel distension and tenderness upon palpation. The patient has a history of a gastric banding 20 years ago, breast augmentation, brachioplasty, and a recent resection of part of her colon. She was diagnosed as having a perforation of the bowel from a complication of diverticulitis, and she also had an abscess, and so they did a sigmoidectomy and put in a temporary colostomy. My patient was discharged, so I don't have any current vital signs for my assessment, but her most recent set of vitals were a temperature of 36.7, heart rate of 84, respiratory rate of 16, blood pressure of 155/96, SpO2 of 97%, and pain of 4, and the pain was localized to the abdomen. The patient also presented with leukocytosis and presented with the comorbidities of MS, depression, hypophosphatemia, and hyponatremia. Although the cause was unknown, some common risk factors associated with bowel perforation can be age or diabetes and use of NSAIDs of glucocorticoids that causes stress and irritation to the gut. For the assessment findings portion of the video, I'm going to be talking about the patient that I had as a replacement. So for cardiac, S1 and S2 sounds were heard, no irregular rhythms. For respiratory, there was wheezing in the upper left lobe, but all the other lobes were clear. For GI, the abdomen was non-tender, it was round and normal for the patient age. For pulses, the radial bilateral pulses were at a +3 and the pedal pulses were at a +2. The patient did have a slight pallor but was still warm to the touch. Patient's eyes displayed all signs of Perla. She had strength in all of her extremities and tone in all of her extremities. Her left lower limb, however, had slightly decreased strength, but she was still able to move it. And the patient was alert and oriented ×4. Now back for diagnostics for my original patient. The patient had a CT of her abdomen and pelvis, and this is what showed that there was a lot of backup in the colon. And so they decided to do a sigmoidectomy that ended in an ostomy, and that is going to be temporary for the patient, and just while she gets her bowel back moving properly and gets adjusted to having part of it now gone. For vitals, I again wasn't able to get vitals on my original patient, but some pertinent vital signs that I noticed in the chart was that her respirations were declining the day before she was transferred, with the lowest being 10. And her pain was also increasing, as well as her blood pressure. It was all the way up to 167/95, and that was not normal for the patient. However, I wasn't able to assess that myself to find out why it was raising. For the patient's laboratory values, a lot of them relate to the bowel perforation and the inflammation that it caused, along with the bleeding. So her white blood cell count was at 14.2, which is high, normal range 4.5 to 11.1. Her hemoglobin was 10.8, which is low, normal range 11.7 to 17.4. Her platelets were high at 535, normal range 165 to 450. And then her CO2 was high. This was 28, which is slightly high. Normal is 22 to 26. Her BUN and creatinine were both low. BUN was 5 and creatinine was 0.5. The creatinine was just slightly low. Normal range is 0.51 to 1.21. But the BUN was 5, normal range 8 to 21. Her albumin, which also normally fluctuates with the BUN and creatinine, was low at 2.7, normal range 3.7 to 5.1. A lot of this has to do with the changes in how her body is eliminating, because she's not using her bowel to the full extent like she is used to, and she also has part of it missing, as well as the bleeding and inflammation that came from the bowel perforation is why her hemoglobin is low and her platelets are high, because the body is trying to repair. Also, after surgery, they're cutting in, they're changing things, and they're taking out part of her colon, and so that's also going to cause inflammation and platelet aggregation. As far as medications, the patient was on oxycodone every 6 hours for post-operative pain. She was also on ertapenem every 24 hours. This was IV piggyback. This is an anti-infective for the treatment of the intra-abdominal infection. She was also on fluconazole, which is an antifungal for the peritonitis, and she was on various other medications for her comorbidities, such as bupropion, which is her antidepressant. She was also put on Senna twice a day to try and have a soft bowel movement, and she was also on Protonix for heartburn. My top nursing priority / diagnosis that I picked out for the shift was mainly preventative care, as far as post-operatively to prevent infection and prevent further bleeding. She had just had an operation and had a stoma put in, and I think it would be important to promote education on a clean area and how to work the stoma, what it means, and the kind of care that she needs for that. Her white blood cell count was already high from the bowel perforation, and her H&H was already low, and so I think that it'd be good to monitor both of those to make sure that the white blood cell count doesn't shoot even higher and her H&H slowly builds back up post-operatively. Interventions that I would have provided for my patient would be to administer pain medication when she is dosed for it and when she asks for it. A lot of the times in the hospital, I feel like patients need their pain medication and their nurses don't give it to them in an adequate time frame. I also would want to encourage the patient to move. I think immobility is such a disadvantage for patients in the healing process. I would also encourage, if she had stayed and was put off bowel rest, that she would get the adequate nutrition that she needs, because that would also aid in the healing process, and all of these things together while providing proper education, because she now has that stoma, and keeping the area clean and free from infection. For the post-shift evaluation part, since my patient was discharged, I'm going to evaluate the patient that I had during the clinical. She was a hip fracture patient who had limited mobility on her left lower extremity, but her main concern was pain, and she was mainly there for managing that pain while trying to gain back mobility through PT. But in the morning, she said that she didn't feel up for physical therapy coming that day, but she understood that mobility was important for healing. She was able to get her pain medication, and then PT came, and she got up off the side of the bed and walked a few steps, and she said that was hard, but it was still improvement for her because she was in her 80s, and so mobility was already not the easiest for her. For financial considerations for my patient, I think surgery in and of itself is such a great cost. And so, of course, all the things in hospital, all of her medications, the surgery, the stoma, and all the supplies that goes with that is such a great amount of money. The patient was also fairly young. She was 48 years old, and so I don't know her circumstance. I think that at any age it's hard to pay medical bills like that, but I just don't know where she's coming from, like if she has just the extra allowance to pay for all of that. But I think the biggest part for her comes in still taking care of herself at home. She was obviously discharged pretty early after surgery, and so she's going to have to go home and continue care for herself, caring for the area, keeping up with her physical health. And so I think going home, that's going to cost even more, not just money, but also of her time. For advocacy considerations, I'm jumping back to the patient that I had the day of clinical. Sorry for jumping back and forth so much, but advocacy-wise, I touched on it earlier, but patients are not happy when they don't get their pain medication or any medication that helps them feel better within a timely manner. I saw a lot of times during this past weekend that patients would ask for their medication, and they're not asking for it in a demanding way, but they're asking for it in a way that is something that they deserve. And their nurses would put it off or not place it as a priority in their care, and so it would make them unhappy. And it would put them in further pain, which also makes them unhappy. And so I just think that we need to advocate for our patients and giving them their pain medication and any medication in a timely manner, especially when they're asking for it and it's something that can be due. They're asking for it for a reason, especially in my little old lady that was 80-something years old with her hip fracture. She was the sweetest thing, and she was not demanding at all, and she was asking for her pain medication. And when I brought it back quickly, she said she was surprised because that never happened in the entire stay she had in the hospital. She said that most people would say that they would be right back with the medication, and then like an hour or so would go by. And so I think that's not acceptable. I think of if it was my own grandparent, how I would feel if they were in so much pain and nobody was treating it. Now for the pathophysiology. The patient had a bowel perforation, but was resulted from diverticulitis. So this starts when diverticulum form in the colon. These are little outpouchings from weak areas in the mucosa and submucosa of the colon. So any weak area of the mucosal wall, whether it's from pressure within the colon or any other area of weakness, it can cause diverticulum. It turns into diverticulitis when the little outpouchings become inflamed. This can be because bacteria got into them and it overgrew. Constipation, if there's fecal stasis and it's just setting there, that can cause inflammation. Sometimes microperforations can occur in the colon, and it's not actually expelling the gastric contents, but it's just enough irritation to cause inflammation. Anything within these lines causes diverticulitis inflammation. If it becomes severe enough, it can lead to decreased blood flow to the diverticulum, so actual ischemia, and in severe cases, necrosis. And so this is what eventually leads to actual perforation, because this super weak and dead spot that is getting no blood flow to it eventually ruptures, and so the bowel contents, so the fecal matter, if the diverticulitis is from bacteria, the bacteria would spill out. Any gas that was in there would go into the peritoneal cavity. This can lead to peritonitis, and in this patient's case, it led to an abscess. And so the body, the immune system, kind of tries to repair the area where the bowel perforation occurred, but it doesn't develop it correctly, and so an abscess occurs. And so it was kind of trying to wall off the perforation, but instead it created an abscess. All of this, the contents spilling out into the peritoneal cavity, is going to lead to further inflammation aside from the diverticulitis itself. And so the inflammatory cascade will be triggered. And so neutrophils and cytokines will be called to the site of inflammation, and they will cause further inflammation. They want to find out what the foreign invader is, the pathogen, and they want to get rid of it because it doesn't belong in the body. This leads to vascular permeability, which is why when we see severe inflammation in patients, we might see hypotension because the vessels are being dilated. We'll see an increased heart rate, and if this isn't stopped, it can lead to sepsis. But for this patient, it was held pretty locally, and so they were able to give her the antibiotics to treat the infection, go ahead and do the surgery, remove the part. of the colon that was necrotic and no longer working. There was no blood flow to it. And so this bowel perforation was an emergency, so they corrected it with surgery. And she was put on bowel arrest. She also had a stoma placed at the end, but that is more of a primary repair, or a temporary repair, to just heal the gut and give the chance to part of the bowel to repair and heal itself, because a lot of inflammation occurred at that spot at one time. But that is the pathophysiology of how the diverticulitis led to a bowel perforation, and this has been my video patho number 1.